Good morning, everyone. I'm just going to talk about the other way of treating the mitral without at least a big surgical incision and without the pump. So these are my disclosures. So I'll just give you an example of a patient of really an unmet need that the previous speaker had spoke about, that you have a lot of patients out there with severe mitral regurgitation and being undertreated. So this is a 39-year-old gentleman with familial dilated cardiomyopathy, ejection fraction 20%, with an LVEDD of 94 millimeter, severe functional mitral regurgitation, and had two actual admissions for inotropes for heart failure. So it was referred for me actually to our center for cardiac transplantation. So, well, I guess what do you do with them? Well, I guess you could go directly for transplantation, or you could go for something less invasive. So one of the things that we do at least in our center to look at some of this patient is that if we could delay their transplantation, maybe we'll benefit from them. That transplantation had limited lifespan. So one of the strategy we go for is the mitral clip, that which previous speaker has spoke about. So I'm not going to go into that. So we did actually that. We sent the patient for mitral clipping. So the patient underwent, was in the cath lab, and then they applied the single clip. And what happened is this had severe residual mitral regurgitation, which we've seen sometimes. So maybe perhaps some other very experienced mitral clip center might say, we'll put 3, 4, even 5 clips on it, and then see if we can stop that. Well, first of all, it costs more. Second is that you might get mitral stenosis, which we all operate on patients that we come back with mitral stenosis with that. So do we have another strategy? So one of the options is, well, how about a replacement strategy with a catheter base? So a lot of people think, well, replacement should be quite easy in this area. We did tons of TAVI. Well, could we use the same strategy to do that? But there's a lot of barrier putting a valve into the mitral space. Is that the mitral valve is D-shaped, it's not circular, and it had no fibrotic or calcified structure to anchor the valve. So you cannot just use radial force for that. And there's many other structures around the mitral valve. You can see, the aortic valve, conduction system, complex subvalvular structure. And one of the things is that all the prostheses so far are quite big. So you need a bigger platform to deliver the valve. In addition, we don't really know how to measure the mitral valve. How do you size it? What size valve do we put in? And there's a lot of technical issues that need to be resolved. So one of the things that we've been working on since 2013 is that to actually study the mitral valve in a more extensive fashion using cardiac CT. We tried many methods, using echo initially to measure how to resize them, but I think CT was the more accurate method, and we devised a method of, which get cut off here, is that to actually reduce the circumference. In addition, the commercial or called TT version of making it a flat version of the mitral valve. And we also did is that we can clone now the device actually virtually into that mitral space to exclude patients who had this case of a severe left ventricular outflow tract obstruction due to the angle and also the septal bulge, and also due to, well, the size of the device you have to put in. And this is definitely not a patient appropriate for a transcatheter mitral valve replacement. So this is one that you can do a virtual implant into a device. We can actually clone different devices. We have the dimension of those devices, and then we put it in and see. We look at what we call the neo left ventricular outflow tract and make sure this is an appropriate patient for such. We developed that and should be published multiple papers on that area. Now there's multiple devices, more than 20 devices now in development, and many of them actually gone into human. And this is just a simple list of it. So I'm going to go through this 7 devices, and now actually 8 devices actually be implanted. One device actually did not really, except for the really initial news release, they did one, with really no data on it, so we can't really speak about it. So the 7 devices actually been implanted so far, started in 2012 with the cardiac AQ device. Up to now, the Caisson is the latest, newest device. So the cardiac AQ device is being implanted by Lars Sonnegaard in Denmark in 2012, a long while ago. So you would expect that with any new technology, you have an early uptick. We should have thousands of this implanted in, but at the moment, only 100 and about 130 of them out there at the moment. So the initial device is a transeptal transvenous device. And now, actually, a new transapical device that they have also on the platform for certain patients, and was acquired by Edwards for $400 million in 2015. So what they did, well, the patient was a very sick patient, so they didn't survive the first 30 days. Subsequent implant, this is an implant again done now instead of transeptal, transapically. This device is a circular device. It actually, majority of the device sit in the atrium. So one of the advantages is that the device is in the atrium, so you would less likely causing a left ventricular outflow tract obstruction. And how it does anchor itself is by multiple anchors or hooks that hook onto the mitral structure to sandwich the mitral structure between the ventricular portion and the atrial portion. So they did, again, the first case was successful implant. However, it was it didn't survive the patient. Technical success so far, they did 13 patients. The mortality, we say, is not very acceptable, over 60%. And they're conducting a trial, a feasibility trial now in Europe, US, and Canada. Now, second device is actually one of the better devices that, at least in the outcome, is the Tendyne device. It's a D-shaped stent with a circular inside valve. It's delivered through a 30 French transapical system. The first done was done in Paraguay with an acute study. So what they did is in 2 patients, they put the valve into patients are surgical. They are on the table, they did an apical implant, they observed the patient with intra-op TEE for 2 hours and see how the device performed. They did well, the 2 devices, and then the patient was converted to one for mitral valve repair and then mitral valve replacement. A study like this probably would not fly in North America or in Europe, but it did it in Paraguay. But then subsequently, the first actual chronic implant or first actual implant into human was done in Australia by the Muller Group. And it was acquired as a device by Abbott for $250 million. So this is an implant performed by Neovasc in England with anchoring into the apex. And they have actually finished their feasibility trial and published the result in JACC with 30 patients with SDL score 7.3%. Very, many of them very successful implant. The 30-day mortality is only 1 patient, and very good, exceptional good hemodynamics with very little perivalvular leak and good results. And patients do improve actually significantly into the heart failure classes. Another device is the Fortis, and you can see this animation is the apical delivery. Quite a big device though, 42 French. What it does is it had the atrial portion and a ventricular or leaflet capturing portion, pedals that capture the A2 and P2 for anchoring. And the whole device is covered by this fabric to try to promote endothelialization and decrease perivalvular leak. So first you deploy the atrial portion, and after you grasp the A2P2, you push the device into the atrium, and then once you satisfy, then you release the pedals and capturing and fixate the device into place. So this is the implant. The first implant was done Vinny Papat in England again in 2014, and this is the implant done by our center. Very good result. However, still with the 13 patients they have done, still very high mortality, almost 40%. The trial was halted due to one of the problems we have facing TMVR is you have a big ventricle, you have a big atrium. Most of the patients atrial fibrillation, valve thrombosis. You have to worry about that. The washing is not as good as you think with a patient with a good ventricle. So the feasibility trial has been halted. Another device is the formerly called 12, and is now purchased by Medtronic. They changed the name to Intrepid, and it's a 24 French transapical delivering system. The uniqueness of this device is that it had an outer anchoring stent and then an inner working valve. So what happened is that you actually have different sizes of outer ring, so you can fit different anatomy. Then you have one central, single-sized mitral valve, around 29 millimeter in the middle. And one of the advantages is that, well, you have a lot of motion in the mitral valve. So you you isolated the actual valve portion from the motion of the mitral annulus. Maybe perhaps fracturing will be less likely in the stent. And also that you're not going to interfere with the leaflet motion with that. So the device is first implanted in Krakow in Poland in 2014, and it's acquired by the Medtronic for $458 million. So the first 38 cases were presented by the Michael Whedon and STS with the preliminary results of 95% success rate of implant, however, still get 30% mortality. Now, 80% of them, of the patient who survived, definitely had improvement in the symptoms. Another device that newly just implanted in 2016 was it's called High Life. It's a privately owned company in Paris. The uniqueness of the next two devices is they actually had a dual system delivery. So the first, they deliver a ring subannulally through a retro-aortic fashion into the mitral annulus. So then you deliver a valve transapically into that ring. So, and you're capturing the leaf at the same time, so they help seal off the perivalvular leak. And also, it maybe land to another system that you could actually put in any other type of valve. So maybe make it easier. So the first case was done by the Rudi Langer in Munich in 2016. However, there's no published result at the present time. The next system, again, is a dual system. It's by the Caisson company out of Minneapolis. And it has a dual stent. It actually had a anchoring portion into the annulus, and then the valve is delivered. This system, though, is all fully transfemoral, venous, and transeptal. And the first case was done by Matt Williams in New York under the trial setting in 2016. Other cases has been done in Canada, in Toronto. At the moment, there's no published results set. And was recently, this company has been purchased by LivaNova for 72 million. You can see the price drop from 400-something million to 72 over the 2 years. Not the best investment. And so let's go back to the patient that we talked about earlier, that 94 millimeter ventricle, severe mitral regurgitation. So what did we do with them? Well, we did is that we implanted another type of valve. It's called the Tiara. The valve is engineering and manufactured in Vancouver. And it's been done, compassionate cases done in Canada, Italy, and Germany. Actually, one case in Switzerland, which I missed, sorry. And we're doing two trials. One is the feasibility trial in Canada, US, and Belgium, a second trial in Europe for CE mark. And it's been approved in Italy and Germany, and we did the first implant in Italy in St. Raphael Hospital last month. And we've done 30 cases at the most present time. We have a 30-day mortality of 10%, and all those cases did die was all those early cases in the compassionate cases, 2 of those 3. So I'll show you a short video, really shortened video of how this type of implant for TMVR, so typical thoracotomy implant, and apical delivering system through a long rib spreading, a 32 French delivering system. Crossing the valve, and this is all done with a beating heart, not on bypasses. And we centered the valve, then we deliver basically a torn-up system with self-expanding to the atrial skirt. The TE is crucial, as probably 90% of the operation is done under that guidance. And because this is a D-shaped valve, so require the rotation. And then once we do that, we did the first 3 cases with pacing, and then subsequent cases are all done on the beating heart. So once we seat the valve onto the annulus, then we release the anchors. The anchors go into the trigon and the posterior shelf. So it does not rely on the leaflet for anchoring, and it's because it's D-shaped, so you allowed a good LVOT. So what happened to the patient after? So this patient had a well-functioning valve for 18 months. The valve is still functioning well. This is the echo done at 18 months with really no gradient across the valve and no perivalvular leak and no mitral regurgitation. And this patient was extubated on a table and went home in 3 days. So the patient remained in from class 4 on inotropes, got to class 2 for 22 months. But as you know, this is not a solution forever. This is not a cure. This is a temporizing solution for a patient like this. At 2 years, he came back for LVAD, and then I transplanted him 28 months after that. And this is the explant of the Tiara valve with no calcification. There's no fracture of the stent. Again, well, N of 1. That doesn't tell you much about the durability of this type of valve, but however, at least I would call that a success. So just in summary, there's definitely unmet need for mitral valve surgery, and that is require a multidisciplinary team to approach this solution. Mitral valve repair, which the previous speaker said, definitely very low risk. However, the effectiveness is questionable. There's modest reduction in mitral regurgitation, and is recurrence, a lot of recurrence of mitral regurgitation. It's probably an option for patients who's non-surgical or high risk, and then with likely with mostly degenerative diseases. And I'm just going to stop here, and then I think the TMVR is going to be a solution as just one of the options for all patients.
Thank you, Anson. Very, very interesting. Thank you. Very, very interesting discussion.